management of aphakia, especially in combined surgeries. This is one particular case scenario where I think still DSEC is much more. Just a minute, my slides are auto moving. I have to stop that. Yeah, I'll just do that. Okay. So these are the case scenarios where DSEC is still a viable option in the era of DMEC and PDEX. And this is a challenge in itself, because the whole principle of endothelial keratoplasty, as we do in normal DSECs in case of pseudophakic bullous keratopathy, change, and due to the difficulties of empty cavity. So we have to choose the type of IOL depending on the type of IOLs that techniques that we are comfortable, and we are going to discuss about the different strategies that we use as compared to normal PBK. And the major difference is due to lack of support and barrier from the anterior and the posterior segment. And most of the time, these cases have vitrectomized cavities, so the air bubble tends to go behind, and we are not able to achieve a full air fill in case of DSEC. So the intraocular lenses that we usually use as ACIOL, the main problem is there's no customization in size. So most likely either the lens is loose and mobile, which will cause an early failure of the graft, or it's too large a lens for the sulcus, for the wide to wide diameter, so that we have a crowded anterior chamber and again a failure. So it's not a very good option and it's not a primary choice. Iris claw lens is a very good option, but it's only useful in case of a good iris support. Sometimes dilations post operatively are an issue for posterior segment evaluations. And I generally do scleral fixated IOLs with my retina colleagues, as most of my cases are gifts from my retina colleagues who have done multiple surgeries previously, silicone insertion, removal, and whatnot. And that most of the time, the cavities are fully vitrectomized. So there are the cases that we iatrogenically produce aphakia are dislocated IOLs. There could be loose ACIOLs or just aphakias with iris loss. So the concern from DSEC in these cases definitely first is poor visibility. So any intraocular procedure that we are planning to do should be a sure shot procedure, and which we are very much comfortable in it. Vitrectomized single cavity is another challenge for DSEC. There are multiple leaking ports if it's a combined procedure with a retina VR surgery. So these leaky ports lead to post-op hypotony and can lead to graft detachment. So this is my first case, which has a corneal decompensation with interior dislocation of the whole IOL bank complex. So the plan was to do an IOL explant and do a scleral fixed IOL and DSEC in this case. So in this case, the whole IOL bank complex was sinking down with a stromal edema. So we planned to do a scleral fixated IOL. As with any surgery, we remove the epithelial for better visibility, as we have been discussing. We tend to make the scleral incisions, scleral flaps prior to any of the procedure. And it is important that we use the same scleral openings for using our pars plana vitrectomy, so that to minimize two vitrectomy ports. After that, the IOL back complex is cheesed out and taken out from a scleral tunnel. So this scleral tunnel is would then be used for inserting our DSEC graft. A pars placenta plana vitrectomy was done. We use a handshake technique to grasp the leading edge haptic of the IOL, take it out from the beneath the scleral flaps. It is done on either side, and a tract is made on either side with a 26 gauge, and the haptics are taken. It's a routine standard cephalocephal procedures. So I generally like to seal all my suture, put an additional suture in the haptics and seal all the flaps, and also suture the infusion port. So this is very important to prevent the post-op hypotony. So once this is done, is as good as a fresh case, a case as a pseudophakic case. I remove my descent by stripping, and then the routine. Uh, it's very important to remove the DSEC in toto, the DM in toto, because there is a chance of posterior migration. So I introduce my DSEC lenticule with a push-in technique. I center it, and this is fairly a straightforward case where the air bubble is very much staying in the AC, and I can achieve a full firm fill. So I routinely place one suture at the scleral tunnel because it's a vitrectomy, and again, I don't want any hypotony with the blink that might happen, and then that can lead to a graft detachment. So this case performed very well with a post-op 1 year BCVA of 6.9. He had a mild cylinder. Luckily, no hyperopia in this case. The second case was a aphakic bullous keratopathy with 180-degree iris loss. This was a case which was due to post-trauma, had a non-resolving vitreous hemorrhage, and the IOL was stuck in the iris. So while removing the lens, we had to sacrifice one quadrant of iris as well. So this was once the retina surgeon has cleared up all the vitreous hemorrhage. Again, with the same technique, flaps were made earlier, and we use the same ports for doing the vitrectomy. It's important that we were trying to do a iridoplasty, but as you can see, it was a very inflamed iris, and any maneuver was leading to much more hyphema, which we didn't want, especially in combining with the case of a DSEC. So vitrectomy was done, and the same technique of SFIL was done. In this case, the major challenge was whether the air bubble would stay in the AC or not. So first, air bubble was injected to check whether the air bubble could stay in the AC. Again, the DSEC, after removal of the air bubble, fluid was injected to completely fill the vitreous cavity so that there is no space behind for the air bubble to go. The DSEC lenticule was injected, and the air was injected. It is very important to fill the vitreous cavity with fluid prior to introducing the air bubble, because if by gravity you would have fluid covering whole of the vitreous cavity, and if you have hypotony prior to injecting the air bubble, so the air bubble would have a tendency to go behind, because there is a huge iris loss and there is no complete barrier. So this is very important in this case. And so a tight fill was achieved. And in these cases, again, a suture was placed and a full fill was kept even in the post-operative period. So generally, if I see a tendency for the air bubble to go behind during the insertion, I try to remove the air bubble after a tamponade of 10 minutes, because as soon as if the air bubble has a tendency to go into the vitreous cavity, as soon as the patient shifts his position, maybe upright or sideways, the air bubble will definitely go into the vitreous cavity due to surface tension. And again, you might have an push of air from behind, which can dislocate the IOL, which can lead to shallowing of the AC as well. So in these cases, it's very important to not have any post-op hypotony, to have all your incisions sutured, and not to leave a bubble, and have the full eye filled with BSS, and have a tight fill after a complete tamponade of 10 minutes with the air. Generally, these cases do much better if the air bubble is not left behind, because with a sudden jerk, if the air bubble goes behind, that can lead to much more problems rather than the graft detachments. So this case also did fairly well, but just due to the enlarged pupil, the patient had glare and had some difficulty in vision as well. So coming to the third case, this is also a case of a post-corneal tear repair with lensectomy and vitrectomy. So this case had a silicone oil filled and then a silicone oil removal, following which we can see a partially absorbed iris, which is just transilluminating. So practically this was just a very thin papery membrane. So we didn't have any iris support in this case, and so we planned an NADDI IOL in this case. So which is a large PMMA 9mm optic with 4mm clear zone optics with C lobes. These have holes for sutures, and these are not glued IOLs. These have to be sutured into the sclera. So the surgery started with making a very large tunnel. It was about a 10mm tunnel. It's very important to have a watertight tunnel, so that it doesn't leak and cause post-op hypotony. So the iris remnants were also removed, and the standard sutured scleral fixated IOL technique was done. The holes were looped into the Prolene sutures and was taken out by railroad technique, and following which the IOL was placed in the AC. Again, all all the flaps were sutured. Again, a push-in technique for the lenticule. And in this case, again, since it's very important here, you can see that once the air has gone behind, but once I fill the vitreous cavity with fluid, the air bubble comes out in the AC. And that is how we conclude the surgery. So take home point for these case scenarios, that we should have minimum ports for vitrectomy, thorovitrectomy. Watertight wound construction should be there so that there is no post-op hypotony. And fill the vitreous cavity with fluid before injecting any air into the AC. And firm globe should be there at the conclusion of the surgery without any leaks. Thank you very much.